Primary brain tumors are tumors that originate in the brain versus elsewhere in the body. Primary brain tumors can be benign, they can be malignant, they can be either. They can originate from the brain itself, they can originate from the covering of the brain, they can originate from nerves throughout the brain. Gliomas are primary brain tumors that originate in the brain itself. They can either present as high-grade gliomas, and the most aggressive form of that is something called glioblastoma, or they can also present as low-grade gliomas, where they have a more indolent or slow growth pattern, but they can have the potential to become higher grade with time. If the brain itself is being overtaken by the tumor, patients will then have issues with whatever the function of that particular area of the brain that was taken over by the tumor. The first and foremost strategy is a surgical one, so removing as much tumor as safely as possible is the first step for diagnosis, but also for treatment. We have a good guess as to what we think these tumors are based on the MRI, but we need a diagnosis. In all of my surgeries, we use a GPS system, which helps me locate exactly where it is in the brain without having to disrupt too much tissue. Sometimes for patients who have tumors that are in functional areas of the brain, your language or motor, we'll get something called a functional MRI, which is a very sophisticated MRI that allows us to understand the neuroanatomy relative to the tumor. That allows me to make sure that during surgery I can maximize the amount of tumor removed, which has a survival benefit as well as a functional benefit to the patient, but also maintain their neurological function. We use neurophysiology monitoring very often. What that means is we can monitor the patient's brain activity with EEG monitoring while they're asleep. We can monitor their strength and their motor response, their sensory response. And then for some of the skull-based surgery I do, we can monitor the cranial nerves, which have very specific functions in terms of swallowing, in terms of hearing, in terms of facial motor function. We can monitor all of that with the patient asleep. Ultimate goal of the surgery every single time is to maximize a safe resection of tumor, which means that I need to remove as much tumor as safely as possible while maintaining and if not improving the patient's neurological function. But we all know that, especially with gliomas, the tumor extends beyond what I can remove, and for that we need radiation and chemotherapy and other types of systemic therapy. Because these tumors can be difficult to treat, it is incredibly important to handle all types of brain tumors with a multidisciplinary team. We have to think of novel approaches and exciting ways to keep these tumors at bay. And so that's where clinical trials and a robust scientific community, such as ours at Yale, is so important. We're so fortunate to be at Yale. Everything's being done here. It's such a group of highly brilliant, talented, ambitious, and motivated people taking care of people with brain tumors, but also working in the laboratories. And so we're able to translate that work into our patients' care.